But does not happen at all, or do any complications happen if you do a premature fusion? My question is to Dr. Ashok.
Good question to tackle. The thing is sometimes hand is closed. Here is a way you can get it. If you're talking about AAS or non-SMS coding. In SMS coding, most of the time you don't have an option. If your curve is say 75 and any other 9, you have to take the child. And the previous worry was when there is an anterior growth left and the child goes during puberty, that's got a function. With anterior segments going back and but with the 3-column purchase, it's medical schools at all levels. Thank you, that actually doesn't happen.
And I apologize for not being. In addition, it needs.
She has also got experience dealing with children, especially more so with the usual complications, plus now that gene therapy has come in, the special liver complications as well. Welcome both of you. So we start off, we've got 15 minutes. So we start off with asking them, what in your view are the things, Mr. Deshna, would you mind telling? What in your view are the things that you see in a child, infant or an older child with SMA?
Thank you. Good evening, everyone. So the categories, they are very much underweight. They don't have any muscle mass, so there are a lot of deficiencies in them. And the other categories, they are overweight. Mostly those who are SMA2, we get that they take a lot of junk food, and there are deficiency of vegetables and fruits. So these are the two categories. And for that, what we do that for the category who are very much malnourished, we just try to feed them with good nutrition. And sometimes we see that due to the swallowing difficulties, they cannot eat the food properly. So in that case, we have to depend on the tube feeding. And for those who have tendency of getting overweight, for them we have to restrict the fried food, the junk food and all. And what we have seen in both categories that there are a huge problem of constipation, and due to constipation there are problem of GI reflux, and it is very obvious that if there is GI reflux, then there will be that create pressure on the pulmonary system, and we all know that these SMA children are suffering from respiratory distress. So what we do that for both the cases, we try to give them easily digestible food, so that will not create any problem, that will be digested easily, that will be absorbed easily, and there will be that no constipation. So soluble fiber rich food, low fat diet, and whatever will be easily digestible. This is our target.
Thank you, Mrs. Deshna.
So in terms of gastrointestinal complications, as Mrs. Deshna already mentioned briefly, common things we see in not just SMA children, any children with neuromuscular disability, gastroesophageal reflux, extremely common, and we just assume they all have it. The degree may be variable. And risk of aspiration because of the dysphagia itself. Oropharyngeal dysphagia, esophageal dysmotility, and risk of aspiration or microaspirations, which are not very evident. And the other thing which she already mentioned, constipation. It's a huge burden with or without SMA in children. It's a kind of our bread and butter. But in children with SMA, invariably they have severe constipation and they don't respond to the traditional doses and kind of laxatives that we use. They need more intense therapy. And the other aspect of my department is hepatology. Hepatology, again, in children with SMA, I recently understood that hepatic manifestations of SMA are actually considered as an extra neuronal phenotype. So that was very interesting. Because so far I was thinking that liver involvement is all secondary to the metabolic abnormalities and the medications that these children go through. But actually there is an intrinsic deficiency of the SMN protein in the liver cells, which predisposes them to actually develop fatty liver without us doing anything different. So it's really important in these children to screen for liver disease, especially when you're talking about gene therapy or some medication that could be toxic to the liver. Screen them thoroughly, do serial LFTs, do a simple ultrasound. some look for fatty liver because that's extremely common. More than 90% of the children have been reported to have liver abnormalities, irrespective of the severity of their muscular phenotype. So that was very interesting. And gene therapy again has brought this liver problem to light, because out of a research article published few years ago that I could see, 325 children there who received gene therapy, when they analyzed, 90% of them had liver abnormalities post gene therapy. It can, most of them had mild to moderate elevations of transaminases, occasionally bilirubin elevation, but few of them ended up with subacute liver failure. So it's really important to select the candidate prior to gene therapy, screen the liver, make sure they don't have any primary coexisting liver pathology, make sure they're not on any hepatotoxic medications, and more important, they're nutritionally well optimized, because that really helps the liver.
Thank you, that is a good.
It may happen because till date in our hospital we have done 7 gene therapy, and out of that only one child developed liver failure. So I think I want to get more data on that. But in general, what I can say that faulty food habits may lead to these problems, because in these children, in the 7 children who got gene therapy, I have seen that the other children were their food habit was okay, but the child who had acute liver failure, she had a little bit of faulty food habits, and her parent was not that concerned about her foods. So I think
Under or over?
Over. So I think that parent counseling is also very important, because nowadays what I see that initially the parents, when we started the clinic in 2017, the parent was used to come for the follow-up, but nowadays they are more interested in getting the medicine, but they are not coming to the clinic for other dietary follow-up. So what I feel this is important, because whenever we are giving a particular diet to a child, if I don't have any clue that whether it is good for him or her, then it will be difficult to follow up, and they are all in the growing age. So each and every day their requirement is getting different. So I think follow-up is very important, and that's it.
Sorry, but especially, it's not just diet to be blamed. Definitely there's a big role to the intrinsic liver defects. These children definitely have abnormalities in fatty acid oxidation metabolism. They have increased lipogenesis, more production of accumulation of fatty acid, more production of cholesterol, triglycerides. However well you manage the diet, diet is extremely important. But pre-selection of these patients also makes a big difference. Many of them have abnormal SL-carnitine profiles. They benefit from carnitine supplementation. They have mitochondrial abnormalities. They have glutathione depletion. So all that needs to be kept in the back of the mind when you're talking about a liver injury in a child post these medications.
So what we have noticed in our cohort as well, of the 35 patients, actually it was not 90% as reported. We got almost 100% liver abnormalities, albeit only mildly elevated enzymes. But the ones who demonstrated the maximum liver injury were all the ones who were undernourished.
Fair enough. I think that's what I could also get from the literature that I went through. And definitely nutrition plays a big role with regards to liver.
Thank you. That segues to the next question, Ms. Sudeshna. Would you mind saying how would you advise a family? These are children with swallowing difficulties, often not overt. Those who are coming with multiple aspiration, we can easily say, okay, that's it, you've got to get a gastrostomy, or you've got to get tube feeding. But those who are insidiously getting swallowing difficulties, those children who are these children are very clever. They have adjusted to it. And so the very young infant will have feed suck rest cycle. But the older children, 3-year-old smart kid, will just say, okay, I drank this much, I don't want to drink anymore. The parent is saying, no problem. How do you deal with these underfed children? You know on your center chart they are undernourished. How are you going to what are you going to do?
Sometimes I have to depend on the supplements, and what I found that in our country there is no specific SMA supplementation. So whatever I get, whatever for the infant, I just use the infant formulas, and for the older children or for the adult person, I use semi-elemental formulas like this. Because anyway they are on tube feeding, so somebody who is the caregiver, they had to feed them. But the problem arises with the kids who are eating of themselves. So in that case, this is really difficult to feed them with a lot of fruits and vegetables. And protein is also a very important issue because in our, because I'm from the eastern part of the India, mostly people are non-vegetarian. So every day they are taking sufficient amount of protein. But who are vegetarian, for them I have found that there are a lot of protein deficiencies. In that case, we have to make them understand that you have to take this much of protein and in which form, and the form of milk or pulses. Calcium is also a very important thing because most of the cases they have bone weakness. So calcium supplementation is also very important. So this is the thing.
We have a fair number in southern part of the country.